Hi, my name is Dana, and I am making a video for you guys, prospective future nurses, not prospective students, you're already students. Sorry, I'm not good at videos or recording myself or anything like that, so I'm gonna say a lot. Okay, I'm just gonna get started. So I'm just gonna go down these bullet points here of things to go over. What year did I graduate Fortis? I graduated in April of 2018. How long have I been in the healthcare field and what type of nursing have I done? So I was actually a middle school teacher when I first started nursing school. And for the first part of nursing school, I would actually go and teach during the day from 7 a.m. to 4 p.m. and then go to nursing school, the night classes at Fortis from 5 p.m. to 10 p.m. And eventually, especially when clinical started, I just could not keep that schedule up anymore. So then I started working as a pharmacy tech. And then once I passed the Nursing 101 or Foundations class, I became a tech on a med-surg floor, neuro med-surg at Sacred, kind of get my foot in the door there. And then when I graduated, the first job I took out of nursing school was for float pool med-surg, and I did that for a year. If I could go back, and I'm not discrediting float pool at all, I kind of wish I would have started off with a home unit to work on. Float pool taught me a lot of stuff. I floated my third day off orientation by myself. My third day as a nurse by myself, I was floated down to ED holds, and it was wild. I mean, so I wish I would have kind of been on one unit and not gone all over the place. But when I did float pool, I did med-surg, PCU, and I went to ER a lot to take the med-surg and PCU holding patients. And then a couple times I got floated to ICU, which was nice because when I got floated to ICU, I'm not qualified to take their patients. So I usually had their transfer patients that were waiting on floor PCU beds or their hospice patients. And usually I got rid of them and then got to go home early. Then after a year of doing that, I was a travel med-surg nurse for 2 years. I was okay being a travel nurse with only 1 year of nursing experience, and I feel like a lot of that was because I was float pool. I was used to doing a lot of different things, going to different units every day, kind of going with the flow type things. So with 1 year of nursing experience, I became a travel nurse. I had worked day shift as a float pool nurse, and then I worked night shift as a travel nurse. I did 5 contracts in New Orleans on their med-surg hematology oncology floor. And then I did a contract in Tuscaloosa, Alabama on a day shift trauma med-surg floor. And then I did a day shift contract in Montgomery on just kind of a general med-surg floor. I think technically the floor was urology, but med-surg floor is they call them renal floor, respiratory floor, neuro floor, but really it's just a little bit of everything. And then now I'm back in town and I work as an ICU nurse at Baptist, and I've been there for about 7 or 8 months now in the ICU. So in total, from working pharmacy tech to tech PCT at Sacred, and then my nursing experience, I've really been in healthcare for about 6 years total now. Certifications, I got my degree at Fortis, and then I got my BSN at WGU. I was in the RN to MSN bridge program at WGU. I did the first couple of classes of my MSN. I was going for leadership and management, and then with COVID and working a lot of overtime and travel nursing, I just could not give school the attention it deserved. So I ended up withdrawing, and I'm gonna go back and finish my MSN when I have time to focus on it. But right now I'm still working a lot. And actually, I don't know what I want to specialize in, and that's kind of the nice thing about nursing, is that there is so many things to do. When I first started working on my MSN, I was getting it in education because I love to teach. I was a teacher before I was a nurse. I have a bachelor's degree in education, so I was like, why not get an MSN in education? And then I thought, well, maybe I'll get an MSN in leadership and management. That may be a little bit more versatile because I would love to teach like clinicals and sim, but not necessarily lecture. So if I have leadership and management, that will kind of transfer over to the hospital better. You can get an MSN in informatics, you can get an MSN in nurse practitioner. There's just so many things to choose from. So, and I think now doing ICU, maybe I'll do an MSN in nurse practitioner and maybe be like a intensivist NP one day. I don't know. There's so many things you can choose from. Basically, I just don't know what I want to be when I grow up as a nurse. As far as certifications, I have BLS and ACLS, which I always keep current. NIH stroke scale, I always keep that one current. You have to. I used to be CPI certified, but I let that one lapse. You don't really need that one. That one's kind of like, you know, if they call like a manpower on the floor or something, you got a rowdy patient, CPI certification means you can go to that manpower and you're certified to talk that patient down. And that one's more so you use that in psych. I am working on studying for my CCRN right now, and I'll take that once I have enough practice hours. A couple things for CCRN. I'm doing critical care nursing demystified and the Barron's adult CCRN exam, and then on YouTube, Laura Gasparis CCRN. So those are my study tools for that. Nurse residency programs. I did do a nurse residency program through West Florida Hospital when I first graduated. The first 6 weeks was offsite. It wasn't even in the hospital. It was kind of nice because you got to use the equipment before you got to the hospital, so you're not looking crazy in front of a patient. Once it got to the hospital, it got kind of weird. I'm not against nursing residency programs. I just don't know. I think there's more we could do with them to be more beneficial. Everybody that I know that's in one kind of feels like it doesn't really benefit them in any way. So I'm not against it. I just think we can probably find a better way to do them. New grads applying to ICU. So I'm not one of those people that thinks that you have to do med-surg first. I see the benefit in med-surg. It definitely will teach you time management. It will help you hone in your skills, see a lot of different things, a lot of different patients. But if you know that you want to be an L&D nurse, you don't need to be a med-surg nurse. Apply for L&D. Now, if you can't get in the door right off the bat, I don't think you should let your skills lapse. Definitely take a med-surg job until you can get into L&D or peds. I think you can start off as an ICU nurse as a new grad, but you really have to know your stuff. If you were going to do that, I would recommend applying for a tech position in the ICUs and just kind of get your foot in the door. That's not to say that when you graduate that they'll immediately have a position for you. It just helps get your foot in the door. If you have a ton of experienced ICU nurses already working there, then you're more likely to get hired on as a new grad. If you have a lot of newer ICU nurses working in that particular unit, you're not going to get hired because it's not safe to have that many people that don't have the experience to be running the unit. And the biggest thing is learn how to do an assessment, a head-to-toe assessment. I know that you guys have probably done it over and over again at this point. You're kind of like, oh my gosh, I hate head to toes, but you have to know how to do it. You have to know how to assess your patient from head to toe, and you have to know when something changes, especially when you're working in the ICU, because the smallest change with a patient could be a big change. What did their lungs sound like before? What do they sound like now? What did their heart sound like before? What did it sound like now? What did their skin look like? It looks like this now. You have to be able to assess your patient effectively. Also make sure that you study up on pressors, sedation, medications, pharmacology, pathophysiology. ICU nursing is the whole picture of the patient. A couple things I wrote out to help you guys. The most common pressors we use are levo, neo, vaso, and epi. So if you want to study up on those pressors, if you're interested in ICU, those are the main ones. The most commonly used sedation that we use is propofol, Versed, fentanyl, Precedex, and ketamine. Precedex and ketamine are in quotation marks because they're not truly sedatives like the propofol, Versed, and fentanyl. You can extubate somebody on Precedex and ketamine. If they're on fentanyl, Versed, or propofol, they have to be on a ventilator. But you can technically be on room air on these two. They're not really sedatives, they're more like anti-anxiety medicines. Most common inotropes, which increase heart contractility, are milrinone, dopamine, and dobutamine. Vent settings you need to know to work in the ICU. We usually give report on the FiO2, which is the percentage of air, or oxygen, I'm sorry, not air, oxygen. PEEP, which is kind of pretty similar to pressure. The set rate, which is how many breaths they're getting per minute, and the tidal volume, which is the amount of volume we're putting into their lungs. What mode the vent is in, such as PRVC or CPAP, and what size the ET tube is. It is 7.5 or an 8. And then, what does that say? Oh, the placement, 27 at the lip, 23 at the lip, 22 at the teeth. So, vent settings. Most commonly used oxygen equipment is nasal cannula, face mask, venti mask, Vapotherm, Airvo, CPAP, BiPAP ventilator, and non-rebreather. And then, obviously, your ambu bag. Most commonly used equipment that we use in the ICU is IV pumps, feeding pumps, BiPAP vents, CRT machines, EKG machines, bear hugger, and cooling blankets. So feel free to study up on that equipment if that's where you want to work one day. Degree progression, I waited till I was a nurse for a year to start on my BSN. I'm glad I did because I feel like being a new nurse and working on a degree would have been too much. And then, like I said, once, you know, the overtime and all these bonuses stop being offered because of COVID, then I'll probably go back and work on my MSN. But it's just, it's up to you, whatever your goals are, whatever amount of degrees or certifications that you want to have. Qualities of an ICU nurse and general pros and cons. It's any type of nursing is going to be a balancing act between compassion and empathy. Having some thick skin, because people are going to say some mean stuff to you, whether it be patients or coworkers, and distancing yourself enough from that patient to do your job effectively. You cannot effectively do your job. I'm not saying to not feel bad for people or feel sorry for people, but you can't let it get in the way of you doing your job. Good at time management, multitasking, delegating, assessing, charting, pathophysiology, being in a high pressure environment, and around many different personality types, and learning and using new equipment. It's very demanding, very rewarding at the same time. I thought a 10-minute video was gonna be really hard to make, but I'm looking and I'm hitting 13 minutes now. So I will talk to you guys later.